Knee osteoarthritis is something we come across on a daily basis, and there are lots of myths and concerns regarding surgery. Most people think that surgery is always knee replacement surgery. That's why I thought we should clarify the indications for the various surgeries available for this very, very common condition. What is osteoarthritis? It is commonly known as a wear and tear of the joint, and basically the cartilage which lines the bones in the joint starts wearing off, and that is what leads to the rubbing of the two surfaces on walking, on shifting, on any movements, and causes pain, swelling, stiffness, and the decreased ability to move and formation of bone spurs. That is osteoarthritis in general. Symptoms are always pain with activity, swelling which comes on, increased warmth of the area, stiffness of the joints, especially in the mornings and in the middle of the night. If people have to get up, they always complain of pain, that the knee doesn't bend, or even coming out of a car after a journey, they're not able to get up and walk normally. All this leads to difficulty in movements, difficulty to get in and out of chairs, and especially the toilet seat, which is usually the lowest part, a seat in the house, and leads to creaking, crackling sounds, and pain in general. Ladder of treatment, of course, it always starts with conservative management, that is self-management, in which people try to lose weight, do regular exercises, adapt lifestyle changes, which means not sitting on the floors, trying to sit on a higher chair in any room, take occasional painkillers and supplements like glucosamine. Then they come to the medical treatment part, in which sometimes they're advised for steroid injection, viscose supplementation of the joints, anti-inflammatory tablets are prescribed by doctors, which are short-term therapies. Walking aids can be used, and then physiotherapy sessions to decrease the swelling, the synovitis, and to strengthen the muscles around the joint and to maintain flexibility of the joints. When none of this works, comes the stage for surgery, and that is what we are clarifying today. Visco supplementation, just one quick slide on this, can give a good relief from 12 to 18 months duration, but patient selection is most important. It will not work in all patients. Patients typically who need knee replacement, it will not give results, but definitely indicated for mild to moderate patients. And the major benefit is decrease in stiffness and decrease in consumption of pain medicines. So that is how visco supplementation works. It does not decrease the arthritis per se, does not cause regeneration of cartilage. So this is a way to decrease medicines and to maintain some quality of life as till the patient comes to the surgical stage. Stages, this is known to everyone. It goes from mild, moderate to severe, depending on the decrease in joint space between the femur and the tibia. Then the deformities start, the varus deformity, the flexion deformity. This is how generally when patients come to us, we tell them that they have severe arthritis or moderate arthritis or mild arthritis, and how they'll be able to prolong their quality of life till they come to surgery. Now, first surgery is known as a high tibial osteotomy, commonly known as HTO, or patients are told that this is an angle correction surgery for them. And in this surgery, it's very essential that only one compartment of the joint is involved. The knee joint has three major compartments: the medial, lateral, and the patellofemoral. So in about 85 to 90% of cases, it's only the medial femorotibial joint which is involved, which leads to the varus of the knee. And HTO is specifically meant for such patients. Again, important that the menisci should be normal, the cruciate ligaments should be normal, there should not be any instability or locking of the joint. And sometimes we do an MRI before we suggest for an HTO. The angle is corrected, which means the weight bearing is shifted from the medial joint to the lateral joint by this surgery. So the typically indicated for people with a varus knee, but with good range of mobility, good muscle power, and with intact menisci and ligaments. Generally not recommended for people beyond 55 to 58 years of age. Done correctly, it gives good results for a good 15 to 20 years. So the surgery has to be well indicated. Patient should know that the results will come after 8 to 6 to 8 months. It takes that long for a patient to be really satisfied after this surgery. It's not something which works overnight like a knee replacement surgery, but it is a good surgery. As you can see, there are two ways to do it. On your left is what we call wedge closing osteotomy is done, which means on the lateral side, a wedge of bone is removed and the angle is corrected by closing that wedge. On your extreme right side, you see a picture which shows a medial wedge is taken out and the knee is corrected. And that wedge is, again, we put in either a synthetic grafts are available or a bone graft is taken from the iliac crest that is put in to maintain that correction, which we do in the HTO. Before we decide on a HTO, we always do a scanogram, which means a standing X-ray of the patient, which includes the hip joint, knee joint, and ankle joint is taken. We see what is the deformity and what correction is necessary. And accordingly, that wedge is created in the bone, and we correct only as much as is necessary. Overcorrecting will also give rise to a valgus deformity, and that causes a change in the gait pattern of patient. So this is a surgery which is very exact in nature. It has to be well understood by the surgeon. Only that much amount of the wedge is removed or created. And then this osteotomy is fixed by a plate and screws, or sometimes by external fixator, it is done. So it is a good surgery done in the mild to moderate cases, done in the younger patients. That is also essential, and they can get a benefit out of this surgery. Unicondylar knee replacement, which is also known commonly as a microplasty or a half joint replacement, indications are typically same as the HTO group of patients, except in the unicondylar knee patient, that varus deformity which they have should be easily correctable to a neutral axis. If it is not correctable to a neutral axis in the outpatients department, which means you hold the knee and you try to correct it. If you're not able to correct it in the outpatient, then do not recommend them unicondylar knee replacement, even if they have only one joint involvement. There are fixed deformities and there are correctable deformities. For unicondylar knee replacement, it is very important that the patient's deformity is easily correctable. Otherwise, what happens? The unicondylar knee replacement is done. However, the knee remains in varus. So patient will have a varus knee. They'll have a painless varus knee. There will not be pain, but the gait pattern will not improve. So this is very essential. And again, generally recommended, this can be done for younger patients and older patients as well. The criteria being the deformity is correctable, only the medial joint is involved, and there's a good range of movements. So patients should have more than 100 degree of movements minimum. And flexion contracture should not be greater than 5 to 10 degrees, because that is correctable. And definitely tri-compartment arthritis should not be done. This is to be done as an end stage surgery. This is not a time buying measure surgery. So it can be done at 60 years of age, 50 years of age, and at 80 years of age as well. But the medical criteria has to be met by the patient. This is a typical X-ray, medial joint involvement. The unicondylar knee replacement has been done. This particular joint is an Oxford knee with a mobile plastic bearing knee. Again, on the left, what it shows is the typical indications. Now the indications are changing over a period of time. What was very rigid about selection of patients, we have become lax in that as well. And overall, very good results, quick results as well. These two patients were operated at Sims Hospital 20 days ago. These are X-rays after the stitch removal, both of them sitting very comfortably cross-legged. So in this surgery, less exercise is required post-operatively. Rehabilitation is much shorter, and patients can get back to all activities post-operatively. So the younger patients are very happy with this. And the reason, if you look at these patients, they are not old, they are relatively young. They both had correctable deformities. So that's why, but they were consistently complaining of continuous pain, and that's why surgery was recommended to them. Okay. Total knee replacement, when more than one compartment is involved at any age, whether it is 40, 50, 80, doesn't matter, then total knee is a better option. When cruciate ligaments are not completely intact or they are diseased, then total knee replacement has to be done. And it is essential to regain the normal alignment after the total knee replacement, which means the hip joint, knee joint, the ankle joint come back to the normal alignment, and can be done at any age and as and when required. It is a time-tested surgery. Patients are very happy that they get back literally to 95% of activities which they wanted to do beforehand, except squatting and jumping activities. These are the only two restrictions we give on the patient. They can sit on the floor, they can sit cross-legged anywhere. That is also not a contraindication now after surgery. And very nice joints are available now, good material, good plastic inserts. So these are all long-lasting joints. And 25 years is what we quote with the present-day joints available to these patients. So that means a great majority will not have to think of a second surgery. This is a patient we operated this week. Patient is in fact being discharged now. Surgery was done on Monday. This is Tuesday morning's video. First time she got up, and again after knee replacement, she can walk with just a very minimal support. This is X-ray of the same patient had undergone a badly done high tibial osteotomy, in which patients didn't get any correction. The medial joint was not regained as well, and we converted it to a total knee, keeping the plate intact so as not to weaken the distal bone. But this patient is doing very well and going home today. Thank you.